Anyway, to start with, we're going to have a lecture from a great friend of mine, Andrew Cohen from Guy's St. Thomas's. Andrew is a terrific speaker. He and I have toured a little bit together, and Andrew is fantastic company. Andrew Cohen, can you hear me? Are you there to tell us about an update on venous thromboembolism for cardiologists? So it's going to be very simple. Andrew.
Yes, hi Adrian, and it's great to see you, and great to join your meeting in Scotland. It's a very interesting program, and I look forward to presenting the data. I'll share my screen if you like.
All right, thank you very much. Take it away.
Here we go. Hope you can see it. Does that work?
Yeah, it looks absolutely fine from here. Right. Slides are good. All right.
Okay, dear colleagues, it's a great pleasure to give an update on venous thromboembolism for cardiologists. And this is where I work, mainly at St. Thomas's Hospital. We look across the River Thames to the Houses of Parliament, and as you know, in these current times, they're looking back at us quite actively for a few ideas at the moment, and I'm grateful to my colleagues who are covering me. These are my disclosures for research support, consultancy and honoraria, Speakers Bureau, and scientific advisory boards. So today I'm just going to cover very briefly which are the suitable patients for DOACs, and really it's most of them. The evidence for DOACs versus what was the standard of care 10 years ago, low molecular weight heparin or parenteral therapy followed by a vitamin K antagonist. Have a quick look at the NICE guidance and mainly concentrate on extended therapy, and have a quick look at cancer-associated VTE. But my talk is mainly going to be about extended therapy and cancer-associated venous thrombosis. So this is one of the patients that we enrolled in one of the DOAC studies. It's a patient with multiple PE, bilateral PE, and some right ventricular enlargement consistent with right ventricular dysfunction related to the acute pulmonary hypertension that this patient had at the time of the PE. And these patients actually go well on DOACs. This is a second patient that we didn't enroll. This is a patient with a saddle embolus who was hypotensive, also had multiple bilateral PE, but this patient required reperfusion. And then following reperfusion, we used some parenteral therapy, and eventually this patient got on to DOAC therapy, but not immediately. So why am I covering this topic? Well, Adrian pointed out to me that actually the national guidelines in Scotland have not been updated for 7 years, but they're basically what was done about 11 years ago. And since then, we've published data on Pixaban and rivaroxaban with respect to pulmonary embolism management, and we've published all the extended studies. So lots to catch up on those guidelines. These are the studies that drive the acute and medium-term management for the first 6 or 12 months. There are 6 studies involving 4 DOACs, dabigatran, edoxaban, rivaroxaban, pixaban, and they're all large studies, you know, somewhere between 5 and 10,000 patients. The dabigatran studies were 2 of 2,500, and they're quite similar in the sense that they compare to the standard of care. But for dabigatran and edoxaban, the patients had to have parenteral anticoagulation before comparing those DOACs with vitamin K antagonists. But for rivaroxaban and apixaban, they could go on single drug therapy. And they had a more intensive dose of DOACs for rivaroxaban and apixaban in the first 1 to 3 weeks, which really covered the usual treatment of parenteral therapy. Now, here are the results of those studies. And I think the first thing to point out is that there's two sets of forest plots here. The top one covers recurrences and VTE-related death, and the bottom one covers major bleeding. The primary efficacy outcome of all these studies was non-inferiority for recurrences. And you can see that all these studies did achieve non-inferiority for recurrences. And all the point estimates included one. But the really important finding was a reduction in major bleeding, also seen in the atrial fibrillation setting. But you can see that there's about a 40% reduction in major bleeding. It varied from study to study. Some showed significant differences. And I'll point out that in the Amplify study, which we published 7 years ago, there was a 69% reduction in major bleeding, so a 2/3 reduction in major bleeding. And when you look at the breakdown of the bleeding, it's not just any bleeding, it's bleeding into the brain that's reduced by 2/3, and it's dying from bleeding. Fatal bleeding is reduced by 2/3. So important reductions in major bleeding. So NICE, on the basis of this data, made a number of recommendations last year, and I'll just really briefly mention them to you. They talked about quantitative D-dimer testing, which is basically your age over 50 times 10 is the upper limit of normal. So if you're 60, it's 600. If it's 70, you're 700, and so on. And that's been taken up in many studies and other guidelines. They also consider thinking about outpatient therapy for low-risk PE, and they suggested various risk validation score tools. One in particular they recommended was the PERC, or the PE rule out assessment, and that is quite a useful one we could discuss later. But interestingly, they were quite specific about which drugs they recommended. They said start with apixaban or rivaroxaban, and in the patients that are suitable, and then in other patients that have no reason to continue, and they're the patients who have a clearly provoked DVT or PE from major surgery or major trauma. 3 months is enough. But if you're continuing, then continue the current therapy if it's tolerated, but switch to apixaban if a DOAC is indicated, if it's not tolerated, or if you're not on apixaban. And that was based on not just safety, but cost effectiveness, which is so important to NICE. The other point here is that they gave a hierarchy of what they thought was suitable treatment. And they said that you should offer apixaban or rivaroxaban for a start. Then consider dabigatran or edoxaban, and lastly, consider low molecular weight heparin with VKA. And that's based on the strong safety data from those DOAC studies. So what do we do now when we're thinking about extending or not extending treatment? In the past, we recommended, is it provoked or is it unprovoked? It's not so simple now. It's not a matter of whether it's provoked or unprovoked. It's a matter of how it's provoked. So we've developed this sort of traffic light system that says, look, if you've got unprovoked VTE, moderate to high risk of recurrence, consider continuing. If it's recurrent, moderate to high, consider continuing. If it's provoked by major persistent risk factors like cancer or active inflammatory diseases, can think about continuing. If we come to the green box down the bottom, if it's provoked by major transient factor, which is major surgery or major trauma, then 3 months is enough. But if it's provoked by a minor persistent risk factor like a chronic medical illness or a mobilization or perhaps even obesity or renal impairment, then you think they're in the people where you might offer extended treatment to. And if it's only minor surgery or minor trauma, think about in continuing those patients as having something that is not properly provoked. So NICE recommends on extended treatment that for these patients, we should consider using a DOAC, and in particular with rivaroxaban and apixaban, we can use a reduced dose, a slightly lower dose than the standard dose. And once again, interestingly and unusually, they made a specific recommendation to switch to apixaban, once again, based on patients that are suitable for DOACs and patients' cost and the bleeding profile. They also said you could consider aspirin for some patients, but aspirin in the head-to-head studies with the low-dose DOACs have shown similar bleeding profiles and far less effective. So I think aspirin is probably not indicated, but it's better than nothing. This leads to about a 30% reduction. The DOACs lead to about an 80 to 90% reduction. So aspirin if they don't want anticoagulants, but I don't recommend it routinely at all. And then let's move on to the latest data, which is the cancer-associated venous thrombosis. And there have been 3 recent studies, 2 published in 2018, the Hokusai VTE cancer study with edoxaban. The SELECT-D was in 2018, which was a pilot study, basically a phase 2 study with rivaroxaban versus deltaparin. And last year we published the Caravaggio study, which was the largest study comparing apixaban and deltaparin. They're all looking at low molecular weight heparin versus the DOAC, and that's because low molecular weight heparin has a half the recurrence rates that you see with warfarin. And the data I'm going to show you, when it went under a meta-analysis, showed that the DOACs have half the recurrence rates of deltaparin. So really big improvements in recurrence amelioration. Let's have a look at the Hokusai study. It was a probe study, pretty standard design. Patients were randomized to either low molecular weight heparin followed by edoxaban for up to 12 months, or the standard regimen of deltaparin, 200 international units for the first 30 days, and then drop down to 150 for subsequent months. And the inclusion criteria were both DVT and PE, patients with active cancer or a history of cancer in the last 2 years. They didn't include skin cancers that were non-melanomatous, and they avoided patients who had a low life expectancy, a high risk of bleeding, low creatinine clearance, so severe renal impairment, uncontrolled hypertension, and had been treated for a period of time. And these are the results, and their primary outcome was a sort of net benefit combining recurrences and bleeding, and it was a non-inferiority study. And you can see quite clearly with the low molecular weight heparin in grey and the low molecular weight heparin edoxaban in grey and the deltaparin in yellow, that they did achieve non-inferiority. They achieved their goal, but when you looked at the components of the primary outcome, we can see that recurrences, there was a non-significant trend to about a 30% reduction, but there was a 70-odd% increase in major bleeding, and this was mainly GI bleeding and mainly patients having upper GI bleeding, and particularly in patients with GI cancers. If we come to the SELECT-D study now, the first part of the randomization was a very similar design. It was the rivaroxaban on its own versus deltaparin. There was a second randomization, but the enrollment was poor into that, and that part of the study wasn't completed to the sample size. So we're really going to show you the data from the first randomization, and this was published 3 years ago. Similar inclusion criteria, similar exclusion criteria, once again getting active cancer patients, and also excluding patients at high risk of bleeding or on significant doses of antiplatelet drugs. And here are the results here. Their primary outcome was recurrences. And in this small study, there was over a 50% reduction in recurrences that was statistically significant. Small study, so not powered to show bleeding differences, but you can see about an 80% trend to increased bleeding and a significant increase, an over threefold increase in clinically relevant non-major bleeding. Once again, this was GI bleeding, and once again was a majority of it. And once again, they stopped enrollment of patients with esophageal cancers and upper gastric cancers. And then finally, the Caravaggio study, also a similar design, also a probe study. And so patients either got the standard dose of apixaban, 10 milligrams twice daily for a week, followed by 5 milligrams twice daily, or the typical regimen of low molecular weight heparin. The inclusion criteria included active cancer and patients with a history of cancer within 2 years, excluded non-melanoma to skin cancer, but also patients with brain tumours and known intracerebral mets and acute leukemia. And the exclusion criteria were once again patients who had a risk of bleeding, patients with low hemoglobins, low platelet counts, and severe renal impairment. The thing that we knew when we were doing the Caravaggio study is that there were that we wanted to get a high risk group of patients because we wanted to compare ourselves to the other studies. We got an elderly group of patients. They were average age of 67. Over 50% had a PE, and over 80% of events were symptomatic, or around 80%, because we restricted incidental events to 20%. And over 97% had active cancer, and 2/3 had locally advanced metastatic disease, which is most associated with recurrences and bleeding. We also knew from the other studies that they had problems with GI patients, GI cancers, and so we actively wanted to enroll GI cancer patients. We got 20% colorectal, over 7% hepatopancreatobiliary, and over 4% gastrointestinal. We had about 1/3 of our patients with, in other words, with GI sites, but a range of other malignancies, and we also had hematological malignancies in about 6 to 9%. And these are our results. Our primary outcome was non-inferiority for recurrences. And you can see we achieved non-inferiority with dalteparin in yellow and apixaban in orange. In fact, there was a trend about a 40% reduction in recurrences, not significant. It was at the 9% level. But look at the major bleeding, 23 major bleeds with dalteparin, 22 with apixaban. So no increase in major bleeding and no significant increase in clinically relevant non-major bleeding, but a trend to a few more bleeds with apixaban, and these were mainly epistaxis and hematuria that were easily managed. For the major GI bleeding, which was increased in other studies, we didn't see an increase in Caravaggio, nor did we see an increase in major non-GI bleeding. So very good reassuring bleeding profile. And so if we look at this with respect to what the European Society of Cardiology is saying, it's important to point out that they also recommend this low, intermediate, and high risk group, but the high risk group includes active cancer patients, these patients that were enrolled in the Caravaggio, the SELECT-D, and the Hokusai cancer VTE studies. And these are the patients we consider having high recurrence rates and long-term therapy. The standard therapy for cancer is about 6 months. We often keep going if the cancer is still active in these patients based on their high risk of recurrence. So my talk today in summary is that DOACs seem to have a much better safety profile than the vitamin K antagonists, and there are differences between the different DOACs. The NICE guidance clearly recommends rivaroxaban and apixaban. They also recommend an extended therapy that you continue the drug you're on, but if you're having trouble with that drug, go on to apixaban if a DOAC's suitable. And for cancer-associated VTE, seen very good results overall with reductions in recurrences compared to the standard of care low molecular weight heparin, but we see variable safety profiles with increased bleeding with some DOACs, but no increased bleeding compared to low molecular weight heparin with apixaban. So this, I think, is beginning to influence guidelines and practice, which I won't go into today. I'll just finish with these prescribing information slides and just end my lecture there. And thank you very much. I hope you're on time, Adrian.
That's great. Andrew, thank you very much. You can hear us. Andrew, thank you. Andrew has contributed to most of these major trials. Andrew, are you still out there for some questions? I hope so.
I thought I'd finish it 5 minutes early just in case there were.
Yeah, perfect. No, absolutely superb. Thank you for a masterful lecture from somebody who's contributed to, I think, if not all, then certainly most of the trials being discussed, and Andrew's made huge contributions in these fields of haematology. Now, we do have a chance, opportunity for a few questions from the audience and via Slido, so people do submit questions if you like. But Andrew, I've got too many questions ready, but I'm just going to start with, this is like a practical point. With the modern CT and echocardiography, what we see a great deal of now is cardiac thrombus. We see right atrial thrombus, we see LV thrombus. And so we're sort of floundering around saying, should we use warfarin, should we use heparin, should we use DOAC? And to give us the current status of where we are with cardiac thrombus and the use of DOACs.
Yeah, I think if it's right-sided, it's fairly clear we can use DOACs. I think the left-sided, there's been 1 or 2 observational studies that have shown that actually the DOACs don't do quite so well in the observational studies as the vitamin K antagonists, and people are a bit nervous. But there is a randomized trial going on because, as we know, observational studies are full of bias and confounding, and we can't rely on them to make treatment decisions on their own. And hopefully the randomized trial data will tell us what to do with left ventricular thrombus. I think the jury's out there, Adrian. Okay. So that's my view. Right-sided thrombus, no problem. But sometimes I see patients with right-sided thrombus that have had DOAC therapy and it hasn't gone away. And in those cases, I often put them on a more intensive warfarin dose, not based on any evidence, just based on, putting a finger in the air and thinking it might work. Yeah.
Sure. Brilliant. Thank you. I can't read this. There's a question screen that's miles away. I'll be right back. Thank you very much. I don't know why the screen's over there. And this is about superficial thrombophlebitis. How long would you treat that with, and what with? Would you use a DOAC for that? Would you use nothing at all? Yeah. Local binding lotions? What would you do?
Yeah, so superficial thrombophlebitis, it sounds like a pretty uniform condition, but for us guys, it's not. We think about, first of all, whether it's occurring in a native vein or a varicose vein. In a native vein, it's higher risk of turning into deep thrombosis. If it's close to the saphenofemoral junction, it's more risk of turning into deep. And if it's larger than 5 or 10 centimeters, depending on whose work you look at, it's more risk of turning into DVT and PE. So what do? Well, you probably treat them for at least 6 weeks. You can use low molecular weight heparin, you can use fondaparinux, and you can use, there's rivaroxaban has also been used, but I think DOACs in general can be used. Do you go 6 weeks or 3 months? If they've got cancer, I'd go a bit longer because the outcomes are worse. If they haven't got cancer, I'd probably go six weeks of anticoagulant. And you can use prophylactic doses of DOACs, rather than the high dose. But whereas for low molecular weight heparin and fondaparinux, you tend to use the 2.5 once a day for fondaparinux, and maybe an intermediate dose of low molecular weight heparin.
Terrific, thank you. Now, a question at the back. While you're okay, off you go. Quick question.
Sorry, that was myself that typed that, so sorry for that. A lot of admission pathways only talk about DVT and PE, and as a GP, it's quite difficult to persuade the risk for superficial thrombophlebitis and getting the right treatment. Is there any guidance going forward to ensure that this group are not missed for the high risk that they have?
Well, so, and any guidance for thrombophlebitis? We'll put it in the next signed guideline. There you are. I'll do that.
Well, the guidance is not as clear, and that's because some superficial vein thrombosis you may not treat with anticoagulants. So if it's a small varicose vein that's thrombosed, you might use a non-steroidal, you might use bandaging, you might use weight. I think if it's a larger one, as I said, a proximal one in a native vein, particularly in patients with neoplasia, you would consider treating those for 6 to 12 weeks. But there is some guidance. It's the place to look for that guidance is in the American College of Chest Physician guidelines. So they're the respiratory physicians. I'm not sure I've seen it in the ESC guidelines, but I'll have a look at them again.
Terrific, Andrew, thank you. And this is what guidelines are for. Andrew, consider yourself already recruited as the external reviewer of the next signed guideline, which will include thermal flight. It's also going to include something about plane flights. Now, Andrew, tell us, if somebody's had say a provoked pulmonary embolus and they're fine, but they're going to fly into Australia, okay? Yeah. Do you give them pill in the pocket on the day DOAC or not, or nothing, or what do you say?
No, I give them. Look, if they've got a track record of having a PE or a DVT and they're flying, then I'm going to fly by the seat of my pants too and give them a bunch of DOACs, prophylactic doses, 10 milligrams of rivaroxaban or 2.5 milligrams of pixaban. Take them on the day they fly and before they get on the flight, and take them for a day or two after. It's basically witchcraft, but in a nutshell, low molecular heparin also works, but that's a pain getting injections. Stockings, I don't believe in. I think they're like fanning a patient with a hat, and aspirin doesn't work. So there we are.
Fantastic. And a mixture of real evidence and guided witchcraft. I just love that. Listen, Andrew Cohen, thank you very much for a brilliant talk. Thank you.
Pleasure, Adrian. Thank you very much.